So we'll get started shortly. Let's just see if we can solve this audio processing part. Let's see if our Facebook friends jump back on with us. And hopefully they'll have less problems. It's not running through the same system, is it?
No, it should be okay.
Okay, well, I'm going to get started. We usually like to start at about 8:05. So welcome to the show, guys. Thanks again for watching. Want to just take a moment to say thank you to everybody who is following us for good. And thank you very much for the subscribers, the likes. We love you guys. Thank you for supporting us. It's been really amazing. We're getting international attention for this show. We have people contacting us from all over the place, including clinics and services that want to use us because of what we're doing. So amazing. Thank you so much. We couldn't do it without you guys. It's really awesome that you're all taking part in this. So tonight's topic is, do ovarian endometriomas affect the ovarian response to stimulation when you're doing IVF or ICSI? And this is a really critical topic. We need to talk about this because lots of women have endometriosis and many of those women have infertility. How prevalent is this? It's prevalent. About 15 to 25% of women probably have some degree of endometriosis. Some of those women have severe endo where there are cysts of endometriosis. That's what we call an endometrioma. And when you have those cysts or you have diffuse, sort of very significant endometriosis, it can definitely negatively impact your fertility. So for a long time now, there's been a lot of controversy about what to do in taking care of endometriomas, because if you have an endometrioma and you have the endometrioma removed, that, especially if done inappropriately, can significantly weaken your ovaries, or at least people think it may. Some of the newer studies suggest it does. Some of the older studies actually suggested it made no difference. And then there's other data that said that if you leave the endometrioma in place, the endometrioma itself damages and weakens the ovaries. So the question is, what do you do with these? Do we remove them or do we leave them in place? And this is a really important question because it involves multiple extra steps if you're going to have to deal with it. You may need surgery. The surgery then may require extra time for healing. The extra time for healing may require, bed rest, home. You may need extra hormone treatments such as Lupron, letrozole, and so on. So it's not just a simple, hey, should we do this or should we not? You really got to know what the issues are around this particular topic and how it impacts you. So this particular author did an interesting study where it was done retrospectively across 923 patients at their facility. And they looked at the groups of patients that had endometriomas, which was 101 of them, versus 822 patients that just had other infertility factors. And they wanted to compare the responsiveness of the two groups. So essentially, they compared them after they had already gone through their treatment. And again, that's important. In an ideal world, we have what's called prospective data, which is you start at the beginning and you follow these patients through their fertility cycle and you're recording data as you go. That's really critical because that's the best quality data. So this is not the best quality data, but it's kind of hard to do that in women with endometriomas because you have to have a lot of them to build up a large number, and then they all have to agree. And if you tell them, hey, I'm studying whether or not you're going to respond well, they're not too receptive to that kind of idea. So you need to be very delicate about how you pose some of these research questions. And because of that, sometimes it is easier to look at it retrospectively, meaning looking backwards in time versus doing it forwards in time. So it was a simple observational retrospective study. They looked at all the patients that were going through IVF and or ICSI in a single university center in Spain. And basically they divided them into the infertile patients with an endometrioma that was at least 1.5 centimeters versus the women that had infertility for other issues that were not related to a cyst of endometriosis. So they made the diagnosis by ultrasound. They weren't all surgical. So that's important. You can make a mistake. A cyst with blood in it can look like a cyst of endometriosis. So you can't be 100% sure without surgical confirmation. And then they tested everybody's anti-Müllerian hormone level and their antral follicle counts to have baseline data for how the patients were responding. So anti-Müllerian hormone is the best test we have right now of how your ovaries are going to respond during ovarian stimulation, or at least we think it is. And antral follicle count is just a count of the number of eggs at the beginning of the cycle, which is a reasonable measure of how well you're going to respond. So they basically went through the normal study protocols. Everybody essentially got whatever dose they needed. It was not standardized. It was individualized. I actually like that aspect of it. And then they did standard statistical analysis, except for this one number I need to define for you, which is called the Ovarian Sensitivity Index. And that is the number of eggs retrieved times 1,000 divided by the total dose of gonadotropins that were administered in units. And that's a factor that they use to kind of help give you an idea of how responsive the ovary is to the medication. So you're counting the number of eggs versus the dose of medications that you receive. So I'm going to share the results with you for those of you that can see it online. So give me 1 second and I'll pull that up. And we're just going to slide this over. Application window. There you are. Okay, so those of you watching should be able to see that now. For those of you on Instagram, it's a table at the bottom there, so I'll read off the numbers to you guys and you'll understand what we're looking at. Okay, so this is really the meat and potatoes of this study, so this one should be short and sweet tonight, and we'll have more time to discuss your questions, hopefully. So the first thing they looked at was the total days of stimulation, and in the endometrioma group, they had 9.9, and in the no endometrioma group, it was 10. So there was no difference between those two groups clinically or statistically. So that's good. Essentially the same duration of time. The total dose, however, was statistically significantly different. So the patients that had the endometrioma needed more stimulation, almost a full Gonal-F pen or whatever pen you're using. So it was 2,824 in the patients who had the endometrioma versus 2,541 in the patients that did not. So usually these pens come in 300s, 450s, and 900s, depending on which manufacturer you're using. And certainly that's a whole additional pen, which is a fair bit extra compared to, the baseline there. Admittedly, these patients were not getting a ton of medication to begin with. You'd probably see much higher dosages if you were looking at a North American program. Next thing they looked at was their estradiol levels. So the estradiol level was 1,783 in the endometrioma group, 1,875 in the non-group. That was not statistically significantly different, and that's pretty close. You're only looking at a difference of about 100 points in the estrogen level. When you factor in lab error and so on, that's not really very significant. They then looked at the number of follicles you had greater than 14 millimeters at the time of the trigger. So in the endometrioma group, the average was 7.1, but in the no endometrioma group, it was 8.6. So that's actually quite significant. You're looking at 1.5 more follicles in the in the non-endometrioma group. And that can really amount to something because you're almost getting close to 2. And if you're getting up an extra 2 eggs, that definitely signifies that those with the endometrioma may have a weaker response or a weaker ovary. What about the actual number of eggs retrieved? So again, very similar, 7 in the endometrioma group, but 8.7 in the no endometrioma group. So that's hugely critical because now we really are approaching those 2 extra eggs on average. And that again was highly statistically significant. They looked at the number of mature eggs, also important. It's not just enough to get eggs because as you all know, if you've done this, there are little tiny eggs that we chase after so you don't hyperstimulate. And then there are the mature eggs that we can actually use. So when we do these, it's fine to just get a bunch of little eggs. They aren't going to do anything, but they would skew the statistics. So what these guys actually looked at is the number of mature eggs, M2, and those are the ones we can actually use when we're doing our fertility treatments. So in that group, it was 5.6 in the endometrioma group and 6.9 in the non-endometrioma group. So again, you're seeing a higher number of eggs that are greater than 14 millimeters. You're seeing a higher number of eggs that were retrieved, and more of those eggs that were retrieved were mature. Finally, in that ovarian sensitivity index, it was 3.3 for the endometrioma group versus 5.1 in the non-endometrioma group. So these are all really, really important numbers, and important for you guys to see and to be able to recognize. So essentially, at the end of all this, what they were able to show is that the endometrioma group had a much, much lower responsiveness and fewer eggs retrieved than the non-endometrioma group. They then went on to develop these age-specific numbers in the two patients for endometrioma versus non-endometrioma, and they have this neat little graph. But the important thing to note there is that you're going to see less eggs in the endometrioma group based on age than you would in the non-endometrioma group. And so they really kind of confirmed all of this. When they then went on and did additional testing and sorting of all the data to figure out what was going on, they actually were able to show that at the end of all this, when you controlled for the confounding variables, age, body mass index, and so on, the neat thing about this was that they actually demonstrated that the AMH level was not particularly predictive in these patients, and that you're probably better off counting the number of follicles. This is kind of consistent with what we've seen out there in the literature for AMH. So I know a lot of you are completely, taught and stuck on this idea that your AMH is going to determine everything. The truth is, AMH does not determine everything. So when you look at other studies, they have shown that women with endometriomas have a lower AMH level to begin with. And so maybe it's not as predictive in those patients of how they're going to do. It's more important to count the number of follicles in those patients. So again, you'll hear me say this many times, but IVF and fertility care is not about making cookies. We're making babies. So this is not a place where one thing applies to everyone and you can just do like a cookie cutter medicine approach to things. Everybody's care has to be individualized. Everybody needs to have appropriate care and assessment, testing, and treatment for them specifically. So is it a fact or fiction that an endometrioma impacts your ovarian response? It is a fact that an endometrioma can and likely will impact your ovarian responsiveness. You'll already have a lower AMH, and going into the cycle, the yield from your ovaries will probably not be as good as it could be from somebody who does not have endometrioma. And they even compared these in other studies to other types of cysts, dermoids, follicular cysts, and so on. Those patients actually show no difference. It's the endometrioma that's the problem. So many of you are probably saying, well, why shouldn't I have it removed then? The problem with removal is that there are studies that demonstrate that it actually decreases your success by reducing the number of available eggs. And my belief is that has a lot to do with how people do the surgery. So when you're doing the surgery for an endometrioma, the only way to do it safely is to make one single cut along the surface of the ovary. You got to kind of peel the ovary open, pull the endometrioma out, kind of millimeter by millimeter, teasing the cyst away until you've removed it without damaging the outer shell or the cortex of the ovary. It is imperative that you not damage the ovary. If you go in there and you start burning everything and cauterizing everything because you're worried about bleeding or you're worried about the damage to the ovary, then what you're actually doing is doing thermal destruction of all those eggs. And yeah, of course, you're going to have worse response. So it's critical that you're very careful with the ovary. I almost never, ever cauterize ovaries after I've removed the cysts from them, in particular with endometriosis. We have all sorts of agents we can use now that will coagulate the blood, stop the bleeding, and allow the ovary to respond much better without needing any cautery whatsoever, which we know is very harmful and damaging. So if you're very careful, you're probably not going to do very much damage. That's a very technical, highly skilled kind of approach to things. As many of you know, I do a lot of my own surgery. I'm an expert minimally invasive surgeon. So for me, I'm very comfortable doing these things, but you've got to be with someone that is comfortable. I know lots of people who have either had injuries or complications having their surgery done elsewhere in the US. or other countries. It's not something everybody can do. You got to find a good surgeon. And your REI is not necessarily a good surgeon. A lot of REIs have given up their surgical skills just to keep grinding people through the IVF machine, and that won't work. So you got to be very, very cautious with all of this. So thank you again for watching. Make sure you like, subscribe, and comment. We want to know what your comments are for the show. So if you have interesting questions or concerns, let us know, and we're happy to share them with you. So I guess we're going to start taking some questions. So if you guys want to put your questions up, we are happy to do it, and we can go from there. I think I saw one somewhere in here early on. I hope I'm doing good. God bless me. Thank you. I am blessed to have good patients. Is it normal to have on-off spotting between Lupron injections, being spotting here and there for a few weeks? Yeah, it can be. In particular, if you have adenomyosis or a fibroid inside the uterine lining, then it's definitely pretty normal to have that. Otherwise, if your estrogen level is just not low enough yet, you may still get some spotting as well. And it also depends on what kind of a lining you have. If it was stable before, if you had a polyp in there, like I said, a fibroid, adenomyosis, those can all impact things and make a fairly significant difference in how you're going to respond. Do you have questions? Yeah, fire away.
Okay. First question. Does high FSH, low AMH cause cycle length decreasing every cycle from 26 to 22 days?
Yeah, so it certainly can. If you have a higher FSH level, it means that the ovary is kind of screaming at the brain is kind of screaming at the ovary to get it to produce eggs. And if it's doing that, the responsiveness of the ovary is very altered. And so you will frequently see women's cycles first shorten and then lengthen as they approach perimenopausal status. So that is pretty common. We see that fairly frequently.
Getting ready to do an IUI, how many ultrasounds do they do until you ovulate?
Well, it depends on what you're doing. So for example, if you're just doing natural cycle, you don't need any ultrasounds, or even the pills, you really don't need any ultrasounds. We reviewed that here about a month and a half, 2 months ago. Where we demonstrated there was no benefit to doing ultrasounds and monitoring for people that are doing natural or just the pills. If you're doing injectables, because there's a high risk of multiples, you have to have ultrasounds. So typically we can get away with just about 4. Sometimes you'll need more depending on how slow or quickly your ovaries are responding. So an average, I'd say, of about 4 scans is reasonable. Typically, they're done very early in the morning. We get you in, we get you out, and then you're fine by the time you're done enough time to get back to work.
Is it safe to take estradiol until 12 weeks of pregnancy, or would high E levels not good?
Ideally, you stay on the estradiol until the pregnancy is well established. So typically for us, that's up to about 12 weeks, but after that, we stop it. You don't really need to be on it after that, and there may be some risks. So yeah, we just continue usually till about 12 weeks, and once you've hit the 12-week mark, you're good.
After how many failed IUIs should we consider moving on to something else?
So this is a very common question. Great question. How many IUIs should we do before we move on to something else? So typically in the infertility world, 3 is the magic number. After you've tried 3 of anything, we recommend you progress to something else. So if you've tried 3 IUIs with pills, probably time to try shots. If you've tried 3 with shots, probably time to try IVF. You don't necessarily have to try IVF 3 times, but again, it is reasonable, especially if you're in a place where there's funding. And you have enough ability to do it. 3 times is reasonable. And then beyond that, you're really looking at other alternatives, options, maybe investigations.
Is it harmful to transfer embryos from clinic to clinic?
Not unless the truck crashes. So embryos are supposed to be stored in a special device. And then that gets attached to this metal rod. And then that typically, the embryos actually in their special little cryoleaf go into something called a goblet, which is a plastic container. That then gets stuck on this metal rod. The metal rod is then put into liquid nitrogen. And the liquid nitrogen tank in the middle is actually quite small. So you really got to bang that to smithereens for something to happen to it. So short of an accident, it'd be hard to do any damage. In the years that the guys from Core Cryolab have been shipping embryos, I spoke to him. He said it's extremely rare that they ever get any cases where there's damage to the embryos from shipping. Let me take one from here. How does monitoring work for patients from out of town? Do we have to travel to your clinic? We are a couple hours away from Windsor. No, so we can use partners from all over the place. I have a clinic in Toronto that I work at. We have partners in Kitchener. We can use, clinics from all over the nation and from all over overseas to get people monitored. So that's not a problem. If you're in town, great. We'd love to have you here. Enjoy Windsor. But if you're from out of town, we'll make it work without you having to come. Hi, Dr. Victory. I have been prescribed letrozole, progesterone, and estradiol for my IUI cycle. I understand I must take letrozole 2 tablets for 5 days. Yes. But I am unclear on when to start taking the estradiol and frequency. I've been given no directive for this drug. I'm currently on cycle day 5. You've been given no directive because you're not supposed to take it yet. So you will be given instructions for everything that you're supposed to take. Don't take anything until you're given instructions, except for vitamins. So right now you take your letrozole. As we approach the release of your egg, you'll probably start the estrogen if you need it, and then either 2 days after you surge or the day after your insemination, if you're doing insemination, you would start progesterone if they've given you that as well. And that's typically what all of us would end up doing. You don't always need the estradiol, but you may. Is there anything you can do for vulvar varicosities in pregnancy to relieve some of the discomfort? Okay, so some women do get varicose veins on their vulva when they're pregnant. It is very, very uncomfortable. There are maternity compression stockings, which literally kind of come all the way up to your waist and can put some pressure in that area. But aside from something cool or, taking pressure off, which is basically you lying down all the time, there is not really a lot you're going to do that will significantly improve your vulvar varicosities. So I'm very deeply sorry for those. I know they're really wretched and uncomfortable, but that's pretty much all we've got. So use the compression stockings. Yeah.
Okay. So many. Can you go into a second retrieval right after one to bank embryos?
Yeah, so right now we're doing this thing called duostim. So duostim is where you do your follicular phase extraction, so the normal time when we grow the eggs and grow the follicles, and then do the egg retrieval. And then we do the retrieval, we wait 5 days, and we immediately start another retrieval. We had a factor fiction on that. It does appear to be better than just doing the first retrieval. So we've just started doing that for a few patients, and we're seeing what the outcomes are, but the studies strongly support that that is beneficial. So you can do it that way, very back-to-back. You can also do it a month apart. There's nothing wrong with that either, although we created a financial package for our patients to make it cheaper for them if they're doing it back-to-back. But it's obviously kind of 2 separate cycles if you're interspersing a whole month in between. So yeah, I mean, there's a cost difference to you, but there's nothing wrong with going back-to-back, even immediately back-to-back. You can look it up. It's called duostim, and we have a factor fiction on it, and it was a really good learning experience. So that's something that's very, very interesting, up and coming, and a lot of people are trying it now.
Are there diminishing returns on IUI success in sperm count, i.e. greater than 10 million, same as 10 million?
So the total motile count and the pain at the time of IUI are probably some of the most important factors in terms of success. And we just had an IG post on that not too long ago. So your count is important, and the threshold that they were using, I think, was 14 million versus less. So if you're over 14 million, you're probably going to do fine. If you're less than 14 million, it is harder to conceive. They still had success even when your count was very low, but it is more difficult. So you got to really be cautious about that, about the numbers. If you have a very low count, it is time to consider IVF. Nothing wrong with trying IUI. You're certainly welcome to try, and we strongly support it. But you got to, in the back of your mind, be prepared that you may need more than that, and that it may not work, unfortunately. So yes, there is a diminishing return. The lower your count goes, obviously, the lower your chances are. Once you're over that 14 million mark, it probably doesn't make a lot of difference, but below that it does. It makes a huge difference. I'll take one from here. I can't wait to meet you too, Randy. Thanks for saying so. Hi, Dr. Victory. I'm 35 years old, male, and my semen analysis shows good sperm volume, but motility is fair, possibly due to shape. Should I be worried? Should I just go straight to IVF? No. If it's just motility being fair, there's lots of ways to improve that. So if you're overweight, that can be a factor. If your cholesterol's high, your sugar's high, that can be a significant factor. There's vitamins that we use that can improve things significantly, getting rid of all the bad stuff. So toxins, exposures to chemicals, solvents, cleaners, making sure that you're not smoking, drinking, using any kind of drugs, including marijuana. Doing our very best to kind of improve the quality of the sperm. I tell a lot of our guys to sit on frozen peas. That actually improves the overall sperm performance as well. Cold testicles surprisingly work better than warm testicles. I'm sorry, guys, if your wives all bring you frozen peas, please don't kill me for it. But and I'm not talking about eating them. I'm talking about sitting on them. So yeah, I mean, it is definitely an issue, but you have lots of opportunity if the motility is fair to correct that. I would not necessarily jump right into IVF. You can take some time and make sure that there's an opportunity to improve it, especially if you're only 35. If your partner is young enough that she's got time, then it should be fine. If your partner's older, that may be a different scenario, but usually 2 months, 3 months is not going to make a huge difference. Where are we here?
And don't forget Instagram on your phone.
Oh yeah, I will. Here
I still got a bunch.
You've still got a bunch?
Yeah.
Okay, wait, let me take one more from here. How long do I have to wait to get my tubal reversal done? Probably about a month and a half. Amazingly, the surgery center is open, but the hospital is not as open as we'd like it to be. So yeah, it will not take that long for everything to occur. Go ahead.
Okay. I had Escher replaced 11 years ago and wondering if it was the right decision.
Oh, well, that's a huge question. I don't know what the variables are. I mean, there's nothing wrong with an Essure as long as you're not having pain. Some people got pain from them. Essure, for those of you that don't know, is a device you stick into the fallopian tube. So you go up into the uterus with the camera and you thread this thing that looks like a metal caterpillar into the uterus. And then it expands and causes tons of fibrosis and the tube scars around it. So it causes a lot of pain for some people. And it has these little nubs that stick out into the uterus so that you know you've gone just far enough. And the problem with that is for people that did try and get pregnant, those cause problems. So Essure is not the right thing if you're trying to get pregnant afterwards. If you're not trying to get pregnant, it's perfectly fine.
Pre-med here, my parents had me through IVF, and so I want to be an REI. Any advice?
Oh, awesome. So if you're pre-med, study hard. These days, the most important thing is your marks. So MCAT score and your grades at school. Your competition is essentially everybody who has got a 4.0 and went to some foreign country where they helped needy people for a month or two with somebody in, the backwoods of God knows where. So everybody's kind of doing the same thing. What we like to see is that you are easy to get along with, that you are friendly, that you're bright and engaged, and that you've done something to distinguish yourself, because when the entire field is a bunch of 4.0 students who have gone to Africa and India and China and wherever else, they're all kind of the same. Even at that level, everybody's kind of the same. So your personality is important. Your sense of humor is important. The ability to live with you for the next 4 years is important. And so that's what they're looking for. In terms of getting into REI, so once you've done med school, you got to get into OBGYN, which is fairly competitive these days, believe it or not. And then you got to get into REI, which is extremely competitive. So the year I applied, I think they had 200 applicants for one position. So it was pretty tough to get in, and that was in the US. In Canada, it's not as competitive, but it's still competitive. So for sure, you got to study hard, you got to be the best, do lots of research while you're in medical school and residency, distinguish yourself, go to conferences, present. That's pretty much what I did. So you got to be really committed, really dedicated, and be personable. You need to be someone that other people can relate to. If you're all brains and, you're not, easy to get along with, or there's personality conflicts, people are going to probably sense that in you and turn away from you. So make sure you're a personable person. Got another one?
Okay. How does bacterial vaginosis affect fertility, and what can be done?
So obviously, if bacterial vaginosis is present at the time of conception, there's two risks. One is that it alters pH, and that's probably unfavorable to the sperm. Plus, there's a much stronger immune component from the woman because she's probably trying to fight off the BV. And if that's the case, then your immune system's fairly indiscriminate. So if it starts seeing sperm versus bacteria, it's just going to attack everything because all of it's foreign. The other thing that's starting to show up, and I have to thank one of my own patients who found this out for us, and we've used it quite extensively, is that in the actual uterus itself, we're starting to find some of those bacteria now. So if you have Gardnerella, which is a BV bacteria, in the lining of the uterus, that's a huge negative. And so now we're actually testing the inside of women's uteruses to see if there's bacteria there for the ones who have recurrent failures, or recurrent miscarriages, early second trimester miscarriages, and so on. And we are finding a lot of them have not just one, but several bacteria. And so you need to treat those before you can get a good outcome for them. So it's really important to make sure that you are healthy. We're actually initiating a new protocol. I just met with my naturopath on the weekend, where we will be implementing antibiotics first about a month before your embryo transfer, and then 10 days of a probiotic to make sure that we're getting rid of everything bad and putting in the good stuff to hopefully alter the milieu from a microbacterial or microbiome in the vagina. And that has been actually shown to be really important. When you have the right complement of bacteria in the uterus and in the vagina, it actually promotes pregnancy and conception. Whereas when you have bad bacteria in there, it's actually a significant decrease in chances. So yeah, we're implementing that into our standard protocol.
Easy question. Do you have satellite clinics in New York region or London, Waterloo areas?
I have clinics I can work with. Are they mine? No. In Toronto, create for sure. We're working on something in York, so hopefully soon. And but we have partners all over the place. I mean, I talk to fertility colleagues all the time. So two just today from different areas in Toronto. So yeah, if you need something done, just let us know.
What type of patients benefit the most from the Lupron Depot injection?
Endometriosis, adenomyosis, and fibroids. So that's where it helps.
Is it safe to take? Estradiol. Is it safe to take estradiol until 12 weeks of pregnancy, or would high E levels?
No, we answered that one already. Yeah.
And okay, and then I got more for it. I did a funded IVF retrieval. Is it possible to transfer them to you for FET and still have it covered?
No. So your IVF retrieval is, or funding, is allocated to the clinic in which it was done. And we do not have government funding here. So we're working on that diligently. We were just interviewed today by CBC, and we're hoping to do a television and radio interview with them as well. We're working diligently for all you guys to get funding here, but you can't move your embryos, especially if you've already had a transfer. If you've already had a transfer, it's impossible to keep your funding. If you have not yet had a transfer, you can move it to another center, but not to us because we don't have funding yet. So that's just simply not possible. Let me take one from here. So I just saw you last before all this COVID, and you said I was going to have surgery to see what's going on inside with endo. You said one side was blocked. I guess surgeries are put off. So I was wondering, do you think I should just try the prenatal pills and something else that might be able to help me get pregnant in a few months from now? That is because I just want to be able to get these women parts out already because the crazy periods I get and have been getting are getting worse. Oh, you poor thing. The pains have been crazy, but because I haven't had one kid yet, my doctor won't fix me or less. It's a fact I won't ever conceive a baby. Oh, I'm so sorry. Okay, so the pain from endo can be brutal. And so I'd love to operate on you. I would, but we have such limited OR time right now. We're telling everybody it's going to be months. So I am more than happy to try getting you pregnant. As long as even one tube is open, it's possible. So why don't you call the office and we will definitely look at doing whatever we can to help you conceive. And yes, while we're waiting for surgery, it's totally reasonable to do that. I would strongly support that. 49 to 51% thawed sperm motility. Is it a good number for IUI? That depends on what the rest of the performance parameters were. So if it was just that one number, that's reasonable, but I need to know what the count was and how fast they were going and how many were normal. So it's not just the one thing, it's multiple things. Steph, how are you? If you had preeclampsia with your pregnancy, is there a chance of having it with your next? Yeah. So there is a higher chance of having it than there would be in someone that didn't have it, but it's lower than it was the first time, if that makes any sense. So your highest risk of having preeclampsia is in your first pregnancy, and in subsequent pregnancies, the chance drops. But if you had it in your first, you're definitely more likely to have it again. And there is no certain amount of time you need to wait, but we want to do every single thing we can to limit your risks of preeclampsia. So that includes getting weight for anybody under optimal control. You want to be as close to ideal as possible. You want to have your diet as close to ideal as possible, lots of vitamins, lots of healthy foods, low carbs, low cholesterol. And then you want to be taking aspirin. So baby aspirin will hopefully stave off preeclampsia. So that's really important. You got one there?
Yep.
It's endless over there, isn't it?
It is, yeah. That's what I'm wondering. You're like, what do you want to do over here? Okay, here we go.
Yeah.
Are there different needle sizes for different progesterone in oil?
There are. There's all sorts of different needle sizes, but dear God, choose one that's small. That stuff sucks no matter what. So the worst thing you need to do is put in a giant needle too. And because it's going in the muscle, it can cause bleeding. So you don't want a big needle. Get something reasonable when you're putting in progesterone and oil. And there are techniques all over the place for how to make it easier, but do whatever you can to make it as as comfortable as possible, as not uncomfortable as possible. Yeah.
Okay, I got a big one.
Okay, hit me.
I want to apologize for the long message. That's how it starts.
Okay.
So I'm 39. My AMH is 0.54 with FSH at 6.8.
Okay.
My first IVF cycle, I was on microdose flare protocol. Estrogen priming for 8 days.
Oh, I saw that question. Yeah. That was the demi-halt question, right?
Demi-halt, yeah. Demi-halt protocol.
So this patient's asking about something called the demi-halt protocol, which I freely admit I am not familiar with. I will tell you this, though. There is no difference between any protocol ever demonstrated, and it's being compared. So people have tried testosterone priming, they've tried estrogen priming, they've tried human growth hormone, DHEA, they've tried microdose flare, they've tried antagonist, they've tried letrozole, they've tried clomid. I mean, you name it, it's all been tried. There is no difference in the outcomes between any of those. The live birth rates are all the same. The only thing that actually makes a difference is doing more IVF. So the duo stim actually seems to be helpful because you're actually getting more embryos because you're doing essentially another cycle. But there's nothing within each individual cycle you can do that is drastically going to alter your responsiveness. Now, keep in mind, I am a big proponent of saying everything should be individualized for patients. And when you're individualizing, it's really critical to make sure that we're doing the right thing for you. So your biology may better suit you to one drug or one protocol than another. And that can be trialed and tested, with little short starts, especially if you have drug coverage, to make sure you're getting the best response. But overall, when you compare all comers one-to-one, there isn't any difference, and the outcomes are always the same. It doesn't matter which way you're going through it. So don't get hung up on that. I have not heard of the demi-halt approach, but I'll look it up for you. I'm curious. Maybe we'll do that for next week's Fact or Fiction.
There you go.
Yeah.
How do we treat adhesion?
Well, that depends on where the adhesion is. If it's in your uterus, you need surgery. If it's in your pelvis and it's binding up something, it has to be surgically released. There are people that talk about being able to release it with deep massage. That's absolute nonsense. If you go online and you watch any YouTube video, you will see, even my own videos, you will see that adhesions are not something that a massage is going to break apart. So you can't take apart adhesions with massage. So you need surgery, and then even with surgery, 80% of adhesions reform in 24 hours. So adhesions are a really tough thing to fix. My program director in my infertility program, Dr. Michael Diamond, is actually the world leader in adhesions. So that's a lot of what we did for 3 years. And he would say the same thing all the time. Like, there is no way to prevent them. And he actually invented some of the stuff that they use to try and prevent them. So it's really critical to know that adhesions are difficult, but it's always surgical. Always. Let me do a follow-up from here. There's a couple of good ones here. Here, let's put this one up. 19 HCG at 14 days post-ovulation. Is that too low, or does the number not matter as long as it is doubling? So as long as it's doubling, you're in good shape. So if you're doubling, you're probably okay. And that should be fine. But you got to watch it. And that is low, although 14 days post-ovulation is borderline, but yeah, I mean, that's probably a little bit on the lowish side, but watch it and see where it heads. That's really important. How do we get off of that? There we go. Nope. There we go. What's the essence of ubiquinol in infertility? Should I stop taking it once I get pregnant? No. So the essence of it for women and men is that it improves the mitochondrial function, and mitochondria is the energy supply to your cells, so ovary, of course. And so if you have lots of the ubiquinol, then the mitochondria works better. If the mitochondria works better, then the cell works better. So that's the point behind it. Follow up on sperm motility. Here's the counts. Concentration 52.8. What's this other one? FOD count motility, 15.6. So 15.6 total motile count, that's a good count. So that was from the guy that was asking about his sperm count earlier with 49 to 51%. So that's pretty reasonable. Oh, here. Follow-up question from above. 15.6 million motile sperm, concentration 52.8, motility 59, progression 46. That's reasonable. That's reasonable. That's not a bad sperm sample. You should probably get your sperm DNA fragmentation checked, though. So that would be important to make sure it's still good. But no, that's a reasonable sample. Yeah, I would anticipate reasonable results with that. Go ahead.
I have no more right now.
No? Okay. Doctor, I did 2 IUI cycles, however, failed. What causes the failure, and how can I improve the next cycle? Any tips? Actually, Tarek and I just recorded a video of why IUI fails. Perfect timing. It's a good segue. So there's no question that IUI is just inherently not that successful. So on the low end, about an 8% success. On the highest of the high end, you're looking at about a 30% chance. So what can you do to improve it? There actually isn't a lot. I mean, if you're doing the basics, the aspirin, the vitamins, the vitamin D, you've got a reasonable medication, you're healthy, your weight's good, you're not smoking, drinking, drug using, your partner isn't. If you're doing all the basics, the rest is really very much Mother Nature. It's either going to work or it isn't. There is no magic twist or trick or technique that's used that turns IUI from a modest success rate to this like suddenly close to IVF thing. That just doesn't exist. So there's not a lot you can do to improve it. It's do the basics and pray for the best. And do pray, because that actually has been shown to help. How is endometriosis diagnosed? Hey there, I know you, one bright smile. So it has to be done surgically. You cannot diagnose endometriosis without surgery. Some people think that they can, and they're all flat out wrong. It's a pathological diagnosis. You're actually technically supposed to biopsy the site, send it to pathology, and they have to diagnose that there is the presence of endometrial stroma and or glands outside of the uterus in the spot that you've biopsied. So there is no other way to diagnose it. And by the way, in the States, there are some awesomely expensive tests where people claim they can diagnose it, and all of those have been proven to be useless. There was a recent study I posted on which said that they think they found a way when you combine a whole bunch of different markers together, but that is not commercially available yet. So we'll see what that turns out to show. And I hope Northern Cali is doing well these days. Stay safe from all the COVID out there. What are the symptoms on the base of which you diagnose endometriosis in a patient? So the 3Ds, dyspareunia, which is painful sex, dysmenorrhea, which is painful periods, and deep pelvic pain, which just means it hurts up inside there all the time. Typically, women have heavy periods as well, and it's cyclic. It gets worse towards your period. It can be debilitating, cause vomiting. Some women will get diarrhea, that kind of thing. Any suggestions for high prolactin levels, medications or vitamins? I'm not aware of any vitamins that counteract prolactin, but Dostinex and bromocriptine are super easy medications to take for prolactin levels. So you got two meds, Dostinex, which is cabergoline, and bromocriptine. They both work. I like Dostinex, less side effects. I only used frozen donors, so I am not sure about fragmentation though. Oh, that was from the person asking earlier about the sperm parameters. Your sperm parameters were probably fine, so I wouldn't worry about it. They were reasonable. Do you do consults before receiving a referral? We will be starting our third IVF. Not sure which way to go. Feeling very conflicted. Don't start your third IVF until you've had a second opinion. I'd happily help you out. So normally we need a referral, especially if you're in Ontario. But we're seeing everybody very quickly right now. So you can reach out to the office and I will be happy to see you as soon as possible. I would not recommend starting a third IVF cycle till you have answers. It is actually rare for us to need to do 3 IVF cycles. I can probably count on one hand the number of times I've done that for patients. We're usually successful on first or maximum second try. So hold off on that till you have more answers, and I'll do my best to see you as quickly as I can. I can't promise any timing because there are several women in the office that I answer to who will kill me. But don't do another IVF cycle. Wait. Even if it's a month or 2 delay, you're better off waiting. Well, that was the same question again. What is the percentage of live birth with a surrogate using a PGS-tested embryo? Day 12 betas is 55 and going down. Oh, I know about you. I'm so sorry about that. That's terrible. So normally about 60%, but if the intended parent and the egg source were young, in other words, under 37, PGT is useless. Unless they have a known genetic problem, it actually is probably detrimental, so we don't recommend it. And I actually firmly believe it increases miscarriage risk in women in that age group. So it shouldn't be done. So I would avoid doing the PGT testing in that age group so that they know it's genetically normal. If your beta is headed down, unless it was a 2 embryo transfer and there were twins and one is not continuing but the other one is, there's no reason why your beta should be going down. So that's definitely not good. And I am terribly sorry for everything they did to you in that last cycle. That was ridiculous. Inside information for those of you that are watching. Is it possible to ovulate all dominant eggs 36 hours after trigger shot on the day of IUI? Is it possible? It's not just possible, it's supposed to happen. So yeah, you can definitely release all your eggs. That's what you're supposed to do. Do you have any more, or do you want me to keep going?
I think I have one more.
Okay.
We'll just stop doing that for a minute. Okay. Have you seen PRP ovarian rejuvenation work for women with POF?
So we did this for a previous Fact or Fiction. The answer is it does not work. It does decrease your FSH, it'll increase your AMH, and it has absolutely zero impact on live birth. So I am not yet a believer. I'm not saying it doesn't work, I'm just saying I don't think it works. I had a lady who, and I've told this story before, who went to Greece and insisted that at 48, the PRP was going to be what was going to save her and get her to make an egg and have an embryo. And I mean, it was a disaster. It obviously wasn't. And I begged her not to spend the money and go. She wouldn't listen. She insisted that I wasn't a believer and that it was going to work. And of course, it's not going to work. At 48, you need like 50 something eggs to get just one normal, genetically normal pregnancy out of it. So taking PRP is not going to do that when you have premature ovarian failure. Am I against doing it? I'm not if you can find someone that will do it for a ridiculously low cost. The problem is it's never ridiculously low cost. It's very expensive, and we have no idea what the long-term impact of that stuff is. So it shouldn't do anything to you, but I genuinely can't tell you it's safe. And I definitely can tell you there is no evidence anywhere that it improves live birth. In fact, every study to date has shown that it does not. So I would be very reluctant to let you do that without significant evidence supporting it. Good question, though. My endometriosis flare-ups have been terrible since IVF. Is it from all the medication? It's from the high estrogen levels. So if you're on Lupron and Letrozole, it should settle down. If you're not, you should be. So we need to take care of that for you, Randy. Yeah. Can polycystic kidneys affect fertility and pregnancy? Wow, great question. I don't actually know the answer to that one, although probably. So your kidneys and your ovaries are intimately related and kind of stem off of the same embryological path at the beginning. So yeah, I would be curious. I'd have to look that up. I'm pretty sure we're not going to find any studies on something like that, but it's certainly a possibility. I am the best. Thank you. Should you take aspirin before, during stims, or is that just before FET? Well, we use it during our stims as well, but definitely before FET for sure. And somebody sent us a request to be in the live video. We haven't done that because we've got this multi-format thing. It'll only show up for half. So sorry, guys, we can't do that yet. But maybe someday when Instagram gets on board and jumps on the same platform as everybody else. Should people who have had cysts rupture in the past avoid Clomid? No. Clomid can cause cysts, but you're not at a drastically higher risk. And cyst rupture is pretty common, so I wouldn't worry about that. What is the live birth rate for a day 5 4AA euploid embryo? 60 to 65%. So any euploid embryo has about a 60 to 65% chance. And an AA is going to be a good embryo, so that's pretty good. One or two more questions. How long do you recommend taking aspirin for? The whole pregnancy. We have another Fact or Fiction on that. So go to the YouTube channel, guys. www.youtube.com//DR Victory, Dr. Victory. So all of these questions are answered there. That's why we've been doing this. What have we been doing this for? About a year and a bit? Yeah, so there's tons of these. Like there's got to be 60 videos up there by now,
More.
right? More, plus all the little ones that we do. So yeah, there's tons of these questions have already been answered for you. But stay on it the whole pregnancy. What dose of ubiquinol? 600 a day. And are there any side effects from long-term aspirin use? Not unless you're allergic to it or you're sensitive to it because of bleeding risks. Certainly if you're on steroids or you're a smoker, it'll rot a hole through your stomach. So don't use it if you're either of those, but you shouldn't be a smoker. How to improve egg quality? I love the simple questions. That's a good one. Okay, we're going to end with that. So you need to take lots of vitamins, watch your weight, watch your sugar, have a healthy Mediterranean diet, make sure that you are stress-free, anxiety-free, do everything you possibly can to kind of put yourself in the best health. Make sure your weight is appropriate, your body mass index, and then make sure they're using the right protocol for you. One more from Auspicious Curiosity. All of their embryos are tested. Guess I will be seeing you again. We will see you again. They're under 35 years old. So under 35, they should not have had PGT. Why were they doing PGT? That's ridiculous. I hate stuff that's not good. Okay, one more from, a YouTube question. Hi, Katie. After all the testing and monitoring is done, how long can I expect to get our results? Thanks. Usually within about a month. So once you've done all your testing, we'll get on it right then. Does IMSI make a difference for patients with severe male factor? Not that we know of yet. It hasn't really shown anything significant. It's still kind of investigational. Okay, guys, it is 8:59 and Instagram's about to cut us off. So have a great night. For those of you whose questions I didn't get to, you can post them to our Facebook or our Instagram or on our YouTube. Go to YouTube. We want the YouTube to really explode. So subscribe, like, comment, share. Make sure that you're telling everyone about it. Share it on your blogs and your different groups you're on. We'd love for this to grow. We want to reach as many people as we can. Have a great night, guys, and we will talk soon. And I think next week, hopefully, we'll be interviewing someone quite well known in the fertility world. Take care.